Okay, any trials in acute mania where they tried to do it all outpatient, good luck. Okay, this is not free-range bipolar disorder. This is hospitalized inpatients. Okay, these acute depression studies tend to be 8 weeks, a little bit longer than the 6-week ones. Okay, so, and the maintenance studies can be anywhere from 6 months to 2 years. And the way the FDA writes the maintenance indications, they focus more on the open stabilization phase for the antipsychotics when they're monotherapy. If they're add-on, they talk as if it's maintenance. But the FDA, you can tell by obsessively reading those indications for longer-term treatment with antipsychotics as monotherapy, the FDA does not want these used as longer-term treatments. So the olanzapine indication says something about the 2-week open stabilization phase. They only had to be stable for 2 weeks before they pulled the plug on the olanzapine, rather than the fact that the randomized phase was a year. Okay, so there are certain complexity to maintenance studies. And in estimating harms in maintenance studies, it's particularly vexing because you can front load weight gain with olanzapine and get 30-something% weight gain in the open stabilization phase, and then you only get another 15% or something, and that's all that shows in the randomized phase, and you get a number needed harm of 8 in longer term treatment with olanzapine, yet over 50% of the patients are getting 7% weight gain. So where we were asking, where does NNT or NNH fall down? Well, particularly with respect to harms in longer-term treatment, okay? Because you can do a lot of harm in the short term. So acute mania, I just showed you that already, and this is what Rajiv was asking for, right? Okay. So I haven't put all the different placebos there, okay, and they vary from one to the next, and the general perception is second-generation antipsychotics are more effective but have more side effects. Mood stabilizers are less effective but have fewer side effects. That's the general perception. But the way they have, that's the average dose. I was going over the guidelines, and I think they said 2,000 is the max. Okay, they take it in that little booklet. I think it said 2,000. I think it said 750 to 2,000. Okay, for acute mania. That's not the way things are working now with contemporary trials. Okay.
You're right. And that's just sedation.
Yeah. So this is the sedation you get with it. But there, carbamazepine 700, a little bit on the high side. Okay. So having worked with posts, 600 milligrams in acute mania is a pretty common dose. 700 is a little bit on the high side. And they titrated this quickly. This is what they had to do. They wanted separation by 1 week. The average duration on our inpatient unit is 5 days. Okay, and so we don't do mood stabilizer or second generation agent, we do both. Okay. And it's funny, the people in the inpatient unit are not so worried about sedation, and the ones, funny enough, the people in the outpatient service are worried about sedation. And as the patients get better from acute mania, as their brain metabolism normalizes, it's harder and harder to carry these drug burdens. And we warn patients ahead of time and say, listen, you're going to get more and more sedated despite the fact we're backpedaling. And that's good news because you get more like everybody else. So whatever was there is going away. And so if you look at the sedative effects of these agents, as the number needed to harm for sedation, okay, it's pretty well the same as the number needed to treat. So asenapine is, I guess, the most recently approved second-generation agent in bipolar disorder. Okay, which it's been around for a little while now. They had an active comparator of olanzapine, and despite all of the motivations, all of everything the company is thinking of doing, sometimes it's hard to hide the truth. Okay, and it can shine through anyways. Okay, and yes, you have to take it with a grain of salt. But let's have a look at this. So they run a centipede against placebo. It beats it by 13%. It's in the game. It's a single digit. It's separated in 2 studies. They've got some problems with self-esteem, so they want an active comparator to make sure it's not a failed study. Also, they want to beat up somebody on side effects. Okay. And so olanzapine runs, and this is not a big surprise. It beats placebo. These numbers needed to treat, they're within the range we usually have. Okay. If we look over here, so this doesn't separate, doesn't, you know, if you're thresholding it at 10, they're both in the game. Okay. Now, if you're thresholding it in terms of you only want a single digit, or you want a double digit number needed to harm, well, this one isn't going to make it. And this doesn't come into the indications. So, in 3 weeks, 16% of people had a 7% weight gain. In 3 weeks. A portion of that on an inpatient unit where are not openly encouraged to eat candy bars and stuff like that. So and with acenapine, this is not squeaky clean, okay, but it's not as big a problem. And they warn you all over the study not to do this, but I just can't help myself, okay? So you can do them head to head. This is another thing. If you wanted to get it FDA approved for gaining weight, it's got a single digit. Okay, so this stuff is potent for the good and for the bad. So because of rounding and things like that, the number ends up being 11, okay? And you can see it's 9.9%, okay? Yeah. And over here, 9.5%. The issue is that it all seems to come out in the wash in this pairing up, okay? So you treat 11 people with olanzapine instead of acenapine, you're going to get 1 more responder, but you'll get 1 more person with 7% weight gain. So you're in this situation of how dire are your circumstances with respect to efficacy needs or tolerability needs. And you've got to personalize at that level. Okay? And so choosing the harm, which harm you're going to go with, sometimes it's more complicated. I think with olanzapine it's a little less complicated. We know which one to go with. We can go with weight gain, which will be a surrogate for metabolic problems, a whole bunch of other things. You can get some problematic sedation, but you can usually work your way around it with olanzapine. We were talking earlier on about rescue medicines. So the multi-phase treatment strategy is, you use in maintenance whatever worked acutely, but maybe the best maintenance treatments are ones that don't work all that well acutely because they're like an airbrush, and they combine with the body's inherent defenses to stave off disease. And maybe there are situations where things are really nasty and you have to use a sledgehammer. And so it could be, and I think we see this in bipolar disorder with, broadly speaking, antipsychotics cutting in mania and then cutting out, being used as rescue treatments for mania. It's one analogy that we don't see so much with schizophrenia. That, oh, this is like really acute, we're going to use this now, and it's 50% chance of 7% weight gain, and we're probably not going to be able to continue it. But we're really boxed in, and something's horrible is going to happen unless we get efficacy yesterday, so we'll go ahead and do it. That kind of thinking is very common in bipolar disorders, less common in schizophrenia. So now there are 4 FDA-approved treatments for acute mania in pediatric populations. Okay, the one on the right, there's some technical problems with the ziprasidone study, not approved, but they look more like anti-manic agents than they do in adults. Those NNTs, if anything, are a little bit better, and they're hovering around 25–30% advantage over placebo, and they all look pretty similar. So even though this is a little embarrassing compared to the other ones, they had a low placebo response rate, so the NNT looked okay. I'd say, all right, well, there's not too much to choose between those with respect to guidelines. until you look at the harms. Look at that spike with olanzapine. Now, one of those does look different to me, and in the prescribing information they say don't use this unless you've already tried something else because it's got deal-breaker side effects. And this idea of demoting olanzapine in certain circumstances because of problems, you know, like this is like 41% of people in 3 weeks putting on 7% weight. Now, to their credit, the guys at Lilly say if you put on 5 pounds in the first 3 weeks, you got to get out of there because it's going to be catastrophic. And when I use olanzapine, I still do use it as a rescue med. I read them the Riot Act. I say, you've got to earn the right to stay on this. And you gain 5 pounds the first 3 weeks, you've had it. You're coming off it. And then if they start feeling better, it's like amazing the excuse, well, I'm replacing fat with muscle. And I was underweight before. All these rationalizations come up. And before we knew the magnitude of the problem, you could get distracted by the efficacy. But that is deal-breaker tolerability problems. Look at this. This is one of the lowest NNs we've got, right? 3. Number needed to harm for 7% weight gain in 3 weeks in adolescents. This is just about getting intolerable. It's the FDA let the indication go through, though. So one of the things I think what's necessary for populations, that's a huge problem. For individuals, you can give them a menu of reasonable choices for the main misery that the drug's going to create and say which one do you want to know about and construct your own chart. Okay, so for personalized care, there's a way to deal with it. Overall, all-cause discontinuation is not okay because it's got inefficacy kind of folded into it. And at least when I look at it, we were doing some likelihood to help or harm analyses. Side effects discontinuations is not as sensitive as just spontaneous reports of side effects. So when you try to aggregate these things, they all kind of come out in the wash. And if somebody, if for somebody who's already overweight, weight gain is like a huge deal. Okay, and for somebody who's real jittery and not particularly overweight, akathisia is a big deal. So this is the main deal, though. Okay, this is the biggest problem right here. And so 2 approved treatments, and they're really not too bad. Okay, couple of unapproved treatments, 5 randomized controlled studies, none of them separated on the primary outcome measure. The very first one separated on a key secondary measure. They really wanted this. The multi-phase treatment strategy says use in maintenance what worked acutely. So when do you start lamotrigine? It'd be nice to have an acute indication. And so it wasn't for lack of trying. They focus on the fact that 47% is not all that bad. It's a little less than 50%. It'd be nice to at least have a coin toss chance of getting people better. And the drug consistently performed at about this level, and placebo consistently performed at about this level. And they said, well, placebo worked too good. Well, it's true, but placebo worked even better over here, right? So if you really got what it takes, you can work your way around a 40% placebo response rate. Okay? So this drug didn't make it. Now, is it a piece of junk that does nothing? I don't think so. Is it something that is a near miss that's got good tolerability? I think so. So should there be a place in guidelines for something that's not FDA approved? Well, if you've got a lack of FDA approved treatments that are too toxic, maybe. Okay, and I think that's where we're at in bipolar depression. Okay, so we only got 2 treatments. They're too toxic for prime time. Olanzapine, you see the number of patients who got olanzapine in the pivotal OFC trial? 351 versus 82. This was a self-esteem issue for Lilly or something. Okay, so they had a little insurance policy here. This was the main study. Okay, and it's almost powered up like this guy. And if you look at it, there's enough power to separate on 9%. It was an overpowered pair of studies. Okay, 2 studies pooled. It actually didn't separate on one, separated on the other. Combine it, and separates. But they go to the FDA. They would have loved olanzapine to get an acute indication. That would have been so nice.